an important question, which I think all of you will agree the role of communication, not only in any healthcare practice, but also in our daily living. So, uh, we have an eminent faculty who is the professor of neurology and in charge of comprehensive epilepsy program in the Postgraduate Institute of Medical Education and Research at Chandigarh, Dr. Parampreet Kharbanda. And he is also the chairman of Indian Epilepsy Association, Punjab chapter. And he has served as a governing council member in Indian Epilepsy Association. And he has life membership in various associations. And he has a special interest in communication session. He has been helping us with various educational programs. So I welcome Dr. Param, and I'm sure all of you will enjoy the session. Please make it interactive so that we can learn from each other. So thank you and welcome, Dr. Param.
Thank you, Dr. Sunil Kumar. Thank you for the nice introduction, and thank you. Who's today there? Senior in place of Sri Priya? Who's there?
Senior here, sir.
Senior, hi. So welcome everyone, and usually this is more of an interactive session, and we all have. We may not have too much experience in palliative care or whatever we are doing new, but in communication is like a lifelong thing, as Dr. Sunil said. So there's always very good inputs, and we would want that we have inputs from everyone, and you can put it into the chat box, and me or Dr. Sunil Kumar Senior will keep a look at it, and we'll keep responding to the various things. Let me just share my screen. All right. So all good, you can see and hear. Yeah. Can you see the screens?
Yes, sir. It's clear.
All right, here we go. So to start with is the objectives of what are we going to talk about today, and why is the need for medical communication? What are the barriers to effective communication? The steps which we can take for effective communication, and then there are specific skills which actually help us have more useful communication, like proper listening, rapport building, paraphrasing to help the patient understand, reframing issues where required, and of course, communicating within empathy. Being a neurologist, you keep saying encephalopathy. That's not good. So there's some few points to start the discussion, and the session is like, I would want your inputs on this. Maybe few people can just put in the chat box, what do you think are the main benefits of good communication in the hospital setting? You can also put your views on, do you think that the communication is a learnable skill or it comes naturally to us? And also, if at the end of the talk, if there's anything which is not stressed upon, you would want to, we'll be happy to discuss. So do we have patient comfort? Dr. Chandrasekharan, yeah, that is very relevant. Patient comfort is the most important, because you know why it is most important? Because patients are very uncomfortable, and we sometimes don't know that patients are being so, we are used to, this is our daily place. It's like our office. We come to the hospital, and even if people is sick or dying around us, we have over the time built a bit of immunity to it. Whereas the people who come in as patients are very shocked, and they may not be comfortable. So putting them at ease is an important thing, starting point of all good communication. Thanks. Sunitha Mary says it's a learnable skill. I totally agree with you. I'll give my points on that. A good communication help build trust between. So trust is very important, especially in today's times where, so there are incidents happening, mistrust between the medical setting and the patient or the carers or the administration. And it will definitely help in compliance of the patient. If you make the patient understand, they will comply to the treatment. Clarity is important, as Preeti has written, and comfortable enough. So yeah, as we said, comfortable, only then they'll be able to ask their questions, and even the outcomes may be better, as Joshi has written. Well, yeah, Saloni has a good point that the patient heals faster. Well, yeah, it may be partly there. I'll show you a slide where people have shown this also, some sort of manner. Transparency is important, sympathy, empathy, we said, and again, a learnable skill. Respect silence. Dr. Kangujam says that is important, that there has to be pauses where people may not be comfortable talking. We have to respect that. Basically, you have to take out a little bit of time. And then other things like dignity, respect, ethic, all of these come in. So it's said to be a small part, but it is very important. I'm sorry, I don't have right now. We'll come to the chat box later. I have to see either one of the things, slide or the chat box. So the chat box is right now out. But yeah, all of your suggestions are extremely important and good. And we'll come to that. Regarding communication, learnable skill, of course, it is a learnable skill. Probably my personal view is that it is a mixture of learnable skill and also something comes naturally. So some people are lucky, or they kind of evolved that way, that they can communicate better than some of us other people, and that helps in learning. But it is not, I mean, I used to think that I take a lot of talks in national meetings, bigger meetings of epilepsy, and I said, oh, I talked so much and I communicate my topic well. That is all that is there, but that doesn't mean I am perfect in communication. So this medical doctor communication, the point here is that we all have things to learn. When I did it about 4 or 5 years back, formally, and then I realized, oh yeah, there is so many things which don't come to your mind unless someone tells you. So that is why we have these sessions, that although we may be great communicators, there is always something to learn. So I just have this, which I keep showing, this acronym made for the good parts of communication, the 4 C's. One is candid. Candid means being honest. So the idea here is to make the, communication easy and more bearable. We twist the style sometimes. This is all about, but not the facts. So this is thing we have to be careful of. Sometimes in a good faith to help the people, we may give tall promises. Oh, he will stand up and walk tomorrow. Don't worry, your son is going to be fine. Don't worry, your father or your mother is going to be okay. So that part, in today's times, we have to be very careful in giving, a lofted prognosis. We have to make them feel good. In the same time, we don't have to overcommit. So it has to be a very delicate thing, being candid about it. Clarity, someone already mentioned in the chat box, and clarity is very important, in the language patient understands. Otherwise, sometimes we just mumble some things, half sentences, fast speed, as if we are in a medical class, but they don't get any of it. So clarity is very important, talking to them in their own language. It has to be concise. As someone said, they are not comfortable and they are sometimes depressed because of being in the hospital or in a clinic, intimidated. So if we give too long speech, then they will lose us. So it has to be given in a very concise manner. And the 4th C is, it has to be complete. Because sometimes the biggest issue sometimes in communication, is my video not coming, or is somebody saying that someone's written communication video turned off? Or is it somebody participant?
No, sir. It's about the video turning on.
Okay, all right. No issues. So, complete is very important, because the biggest miss, or you can say, sometimes, as Dr. Sunil was saying, and I keep saying, that communication is important in every relationship. And we had said it, the other person said, no, it wasn't said. That is most of the fights, whether it is friends or whether it is family or spouses there. So completeness of communication, saying it out clearly, is very important. This is a video from YouTube, just showing that that some people who are there, who these are the support sessions, where you are taught to trust people, and this is that kind of a session. And there is a trainer whose hand you can see. You won't hear him say, but he's explaining to the new person in the green shirt that how to build trust, and he'll ask him to get on a stool, and then he will close his eyes, and the people around him will gather around him, and then he said that you have to trust them and ask them to fall. So that is how you will build trust. That he's told him that you'll fall and they will catch you, they won't let you fall, but you have to close your eyes so that you build trust. So that is what this man is explaining, and exactly that is what he does. But as you can see, sadly, he the last point was left, that which side he has to fall, and he falls to the front. So it's made up, for a little bit of, lighter side. But yeah, these things can have negative effects if the communication is not complete. So someone did mention that better outcome, and it has been shown in research that people who receive empathetic care have shown to be better control of their blood sugar and blood pressure, definitely better pain scores, because a lot of pain is perceived pain, psychological pain, emotional pain, as you may have been talked about during the other palliative care sessions. And they don't go for unnecessary doctor shopping and hospital shopping, because they've been explained things properly, and because they've been explained, their understanding of the treatment is better, and better compliance with treatment. So you all said most of the important points here. And another thing is, if they are involved in the treatment, shared decision making, they take responsibility also a little bit of their decision, and that helps us. It's not unnecessarily, somebody can't say that things have been forced upon me. So take them into confidence, and that requires a lot of good communication. So what are the barriers? I mean, we would say things are very simple. So what happens? Apart from that, we are very busy sometimes in busy clinics, busy hospitals. There are other barriers. Some of the barriers are from the patient side. Patient may have a bit of an introvert nature, and many cultures, including our culture, there's a big power difference between the doctor. Doctor is a revered figure, and the patient is like, has to obey, kind of a thing, which is changing. But classically, it has been like that. And because of that, people may not feel comfortable asking questions. They may think the doctor is so busy, why should I disturb them? And even if they have some issues, emotional issues, they will not talk, because they'll feel that is not related to the medicine. And they can be actual diseases, like in my practice as a neurologist, stroke. They may not be able to speak clearly. So we have to find other ways of communicating. I keep talking about movies. So I told about this movie where there is a stroke called locked-in syndrome, where only the patient's eyes can move and the rest of the body below is paralyzed. We recently had another patient like that. It's quite unfortunate. But the story I tell is about a movie called Diving Bell and the Butterfly, where there's this, I think, French guy of a very famous magazine editor who broke his spine, and not broke his spine, he had a locked-in syndrome, kind of a stroke. And they, over some months and years, they learned to communicate with the eyelid batting. And that is how he was able to write that book about a story about the whole thing incident, along with his trainer. So things can happen. If we are interested, we can always get over the barriers. As I said, there can be fear, anxiety, there can be anger. Anger doesn't have to be at the hospital or at the medical professionals. They can be just angry with themselves about their situation. why did this happen to me? Why didn't it happen to anybody else? I was in my prime of my life and this chronic disease has come to me. So that anger causing depression, not being able to understand. In addition, we adding medical jargon to it makes things even more, complicated. This is a clip which I, just recently saw. You can stop recording for this part. And sometimes, after all the things you've said and discussed, patient may not be able to make a decision. And sometimes in that case, we need to hold their hand and, help them make a decision, not make it for them, just help to make a decision. This slide is incorporated because when I do the things for our residents regularly, they keep saying that, we don't have time, which is true. All of this may not be able to in every situation. Everybody, especially in our country, public hospitals more than any other thing are extremely overloaded and busy, and we cannot. But idea is, the whole crux is that the many things which if we make our habit will not take more time. So this is the slide shows that if we make our habit to be empathetic, to listen carefully, keep away our telephone and all those things, actually we may save time by giving proper information in one go. This research shows that if the patient was not given, they will keep coming back. Either they go to other doctors or come back after going out of the clinic room or something and ask questions again. So if we do it well in the first go, actually we can save time in our practice. Now, the patient insecurity, even doctors and medical staff, nursing, we all have our own insecurities. And, whether you're a counselor or a psychologist or whoever, that we are always afraid. We are trained to be heroes, saving lives. And we never trained to deal with failure. Every time we won't succeed. So we are scared. What if the patient starts crying or get angry? So we also have to bring our skills up to deal with proper communication. So as a result of this, many times we'll, keep our conversation very safe. Patient will also keep it safe that times, like when the patient asks, I'm so worried, I can't sleep properly, I have pain in the back. We'll just pick up the medical part. Tell me about the pain. We are so unsure about talking about the softer parts, which we need to be, because they look at us as our saviors. And even though we don't want to come across as saviors, we can at least come across as empathetic listeners. And we all have a tendency to give leading questions. We expect the answer. Like I asked somebody, so I hope you're feeling better today. That is a question which you are almost putting pressure on the patient by asking that, tell me yes, or otherwise I'll be very, sad. So it's best to not have closed question, open questions. Tell me how you are today. It's a big difference than expecting the answer of yes. Give them an open-ended question. So these are very, very small things. But if you go over once or twice, you'll realize that how much, and put yourself in the patient's perspective, that if you're asked this question or the bottom question, how much difference will it make? Another barrier is environment. Some of it is not in our control, like, busy hospitals, sometimes a big room and more than one doctor is sitting there. So there is hardly any privacy, there's noise, there's sound, and that has a negative effect on communication. But there are some things which we habitually may be doing without knowing that we are causing effect on communication, is like picking up our phone in between. Obviously, if you are on an emergency call and you get an emergency phone, you have to pick up. But checking WhatsApp or this thing, it becomes as if you're still listening to the patient, but you are distracted. It's becoming a habit. Everybody is on the phone. So on the patient, it has a big effect. The doctor is not interested in listening to me. Then there can be physical barriers. Sitting behind a big desk and patient at the other end may not be comfortable as much as if you're sitting on the side. I mean, my table is like this rectangular and I'm sitting here, and my patient usually sits on the side chair. So there is a proximity where they don't feel that much of a power difference. So now in the next 5 minutes, we'll go over this three, what we call as basic skill sets in communication. So skill set one is like setting up the meeting when the patient comes in. And if you have the luxury of time, actually you can do everything written here, or at least the main ones which are highlighted. So we should greet the patient, we should introduce ourselves. And again, we walk into patient's room on the round. We never tell who is who, who's resident, who's the consultant, who's the nurse, who's it. Actually, we should tell, I'm Dr. So-and-so, this is my team, this is Dr. So, this is the nurse who's going to be look after you. At least they will know. Many times we enter the patient's room and they said, yeah, some people had come, but I have no idea who had come. So it is important to introduce yourself. And if you know the name of the patient, it's not difficult. Greet them by the name. It's not that we are being formal or being nice, or the reason is they become comfortable. How to make people comfortable so that they open up to you, including the patients. Second is that ask them the list, because people have not, some people do. I know people, especially the older ones who are retired, make a long list and come. Many people don't. They start thinking, but when you ask them, so give them a little bit of time to complete their list, because the important thing may be at the end. If we cut them out after the 2 complaints and start talking about it, before leaving, they say, actually, I also have a pain in the back, which would be the main thing. Let them complete. Give them a few seconds. We can tell them the time. We negotiate the plan. That we, in the next 3 or 2 minutes, whichever, you tell me what you want, I won't stop you. I have total of 15 minutes to spend with you, give or take here and there if required. So let's finish up the history part in the next 5 minutes. Then they'll know there's a time barrier, otherwise they'll lose out. So we don't want them going on and on, but we also don't want to cut them short unnecessarily, so that lose out important information. Second is history building. So as all the motivational people tell you, that active, attentive listening, reflective listening, or in short, listening is very important to make diagnosis, to make the patient comfortable. I think Sir William Osler's comment which we used during medical training, we were told that listen, one of our senior professors used to say, listen history properly, don't stop them, because William Osler said, I'm not sure I'm quoting right, but the quote goes like this: listen, the patient is telling you the diagnosis. Basically, it's a bit of a satire on that we don't listen properly, so we have to do so much investigation. If we had listened to the history properly, we may have got the diagnosis in the first go. So listening is important in any conversation. Ask about impact, ideas, expectations. This is going beyond the medical things. And then, of course, emotion, respect, legitimize. We'll come to that later. And then go to the plan part. So the main thing, if I want to say in this slide, is that make sure that they have got it. Many times we think they do, they don't. I have had it in my practice. I mean, realize very late. I used to write anti-epileptic drugs, which have to given for a few years. And I would say, take it and then come back after 3 months, because that is when I want to see them. Patient can't come. They come in 4 months, but they have stopped the drug at 3 months. So unfortunately. Then I realized that I have to be very explicit about it, that if you can't come at 3 months, you tell me that you have to take it till you come. You ask the patient, what did I say? Doctor, you said come it till I come here. Right. Otherwise, this all thing can, go negative. And then we make some steps. And so these are the basic skill sets which we talk about. Are there any comments or anything which somebody has to make, or I can go on, or you can make it at the end, your choice. But we are the 2/3 kind of part. So maybe if you have any comment, you can put down. I'll stop when I see the comment, or maybe, Dr. Sunil or Senior can let me know. So this slide is about the concept of shared decision making. I am sure you all know about whatever, whether you are a doctor or an allied staff, or, informed decision making. So informed decision making is that previously it used to be paternalistic. As I said, big power difference, which is still there in many parts. my way or highway, that either you do what I say or get lost. I mean, don't come to me. Why are you come to me? You waste my time. And we could have easily seen other patients like you waste our time. So that part we have to shift. One was the first step was informed decision making, meaning give them all the good options. Know your medicine well, give them the proper options. This is also possible, this is also possible, maybe this is a little better, this is its pros and cons, and then involve them in decision making. That way they'll be more ready to take your advice. The last thing, shared decision making, you see, it's a two-way loop. What does this mean? So informed decision is there already, but before taking the final plan, we ask the patient's values and preferences. How is it different from informed decision? Values preference means that, say you're dealing with a cancer patient, and your option is, of course, chemotherapy, surgery, and this and that, and maybe patient is at the terminal end, and it is only going to prolong the patient's life by 2 months, from 4 months expected to 6 months. So that is where shared decision comes, that what is their values, how do they look about life. Many people may not look at longevity as the only criteria, which is quite common in our setting, but quality of life, which is coming now. People want to live well rather than live very, very long. I mean, everyone's different, but this is how things are going, which is in the rest of the world and coming in our society too. So they may want that, I want to be comfortable. And I had somebody in my own family, one of our elders, and terminal metastatic cancer. And the expert said that it is 4 to 6 months, and you can prolong it by 2 months, but chemotherapy, vomiting, and all, but you might live a little longer. He decided no. Said, I want to be comfortable, do the symptomatic treatment, give me the pain relief, give me fluoridesis. There's no fluid in the lungs, I can breathe properly. And that was the decision. It had to be, because even medically we may have preferred a little more. He was very clear that I don't want to go through all this. So shared decision involves beyond the medical statistics, patients' values and preferences. Very, very important in today's times. Then these are very simple things like making eye contact is important. Obviously, we don't want staring down people's eyes. So the best way is a little bit look into the eyes, maybe then look at other part of the face, but not look away mostly. And if we can, even behind mask or PPEs, smile, because your face, eyes can show the smile even if your face is covered. And if you talk nicely, I'm sure we all realize that you can make out the tone, even on the phone. Is the person happy, smiling or not? So use that in the communication also. This is an important thing. As we said, learnable, this is what I learned. Many of us used to do, and we all do, again, in good faith, that when the patient is feeling low or worried or anxious or apprehensive, don't worry. Why are you worried? Be strong. You're a strong person. You're a strong child. You're a strong lady. Many people are in a worse condition than you. See, you stand up. So we are doing that to make them feel better. But now, at some point of time, not today, see if ever, God forbid, you are in a vulnerable situation, if people are just pushing you to stand up and go, you can't, because your mindset is like that. What they need, like, for example, either you have small kids or you're going to have bigger kids, adolescents, and they'll make mistakes, and we made mistakes. And let's say if you're young, see it as a child to the parent. When you have made a mistake and you're sorry for it, you don't want your parents telling you, didn't I tell you? See, I told you this is going to happen. They know that it has happened and it is not a good thing. That time they want just support. Same is for our patients. If we want support in that time, not to be told off, so we don't want to push them into feeling low, that you are very weak. The left side shows that we are almost like implying the patient is being weak. So what is called is normalizing the emotion or legitimizing it. So what we want to say is that anybody in your position would perhaps feel this way. Say, yeah, we will, won't we? If somebody is dying or I'm having a chronic illness, I will be weak and vulnerable. Somebody tells me it's all right. Crying is fine. Sit and cry. I'll be here with you. That's empathy, not crying with them. And that is not what is required. Be with them, hold the hand. It's okay. Considering what you're going through, it's normal to feel this way. So this is what we want to shift from in our statements to our patients. Oh, that is the end of the slides. So I have to thank, contributors, a lot of people from Pallium India and the other community of palliative care, and my collaborators, Dr. Geeta from American College, of Health, Communication in Health, and UCSSD. So thank you, everyone. And I think, yeah, that is end of it. I will stop sharing and we can come back to whatever comments and doubts you have in mind. Dr. Sunil, do you want to add anything?
Thank you, Dr. Param. I think, first of all, I know that there are many people who are here who has a good experience in communication, or they will have some experience of their own. So I would request any of you to share your experience regarding communication.
Absolutely. There is so much to learn. Every day I fail and I learn. I mean, honestly, between us, all what I've said is not what I follow much more than what I followed before I got into communication. And that was when I thought I was very good at communication. But today also, when the OPD gets heavy or end of the OPD, you know how PGI, I don't know, like AIMS, PGI, extremely busy, hundreds and hundreds of patients in one day OPD. End of it, you do lose your cool sometimes. But the best thing is, as much as possible we can do. So it will be very nice if you've had experiences or you got stuck somewhere, or you have a academic comment. As Dr. Sunil said, many of you have been exposed to this thing. So it'll be nice to interact. We have a good amount of time. You can even put your hand up or unmute and we can talk if you don't want to write in the chat box. Any situations you've come across where you got stuck or...
Anybody, please unmute and speak. Dr. Achama says communication is a teamwork. Definitely. Communication is a teamwork, because if we start communicating with a patient something, then we need continuous follow-up with that patient. So it is important that if we have a team, then it will be easy for us to communicate with the patient. But there are even Fakera says, I cannot hear. Can you hear?
We can hear you,
hear.
sir.
Yeah. Maybe I can hear you.
Okay.
Maybe need to check, Fakira, is your speaker on or sound okay? Yeah.
But one thing is that there are many people who practice as a single person. So they may not be able to have more members in the team. So they have to do it their own. So that's one of the disadvantages. But it is always important that if you work as a team, you will be able to do more.
Absolutely. Yeah, I totally agree. And though in simply it is a teamwork, the teams have to be oriented properly. So what many times we see, this thought came from your comment, Achama, that what we see is many times a good prognosis or good outcome is communicated by the senior most person of the team, the boss, and the bad prognosis we send the junior most person to tell or something. That has to be reversed. We feel that it has to be opposite of that, because we have to train our juniors also. So when it is a good prognosis, let the juniors go and tell that. But the serious or any mishappening or something which has happened, the ideally the senior most person of the team should be going. One, you are more well versed. One, you should own up. We should take up responsibility. And I mean, we try to follow that. Even somebody's seen the case or whatever is done, the final briefing or something comes from the senior most person, and more important in a negative outcome. Very, very important. So although teams has to be also done properly.
So Dr. Param, we have two videos, one on good communication and one on bad communication. Shall we show that video so that everybody can understand a few points on good communication and bad communication?
Sorry, I didn't get what were you saying. I didn't get that.
We have two videos, one on good communication and
Oh,
one
you
on
have
bad
videos
communication.
you would like
Yeah.
to show.
Yeah.
Yeah, great.
Shall
Carry
we
on.
do that?
Yeah, sure. We have time now that we can show those brief videos. And I have a video, actually, I didn't, I don't know, it's got corrupted regarding that shared decision making. Maybe next time I'll put that, but please carry on.
Yeah. So Senior, first, I think we will show the bad communication video. Senior, you can
Sure,
share.
sir. Sure, sir.
Mr. Arun Kumar is suffering from lung cancer. Radhika.
Actually, you are absolutely right. A good communication is quite necessary between the patient and the medical staff because without proper communication, they feel negativity, and they become more worriness. They become more worry and they feel anxiety about the disease, and especially the rural people who are feel very. Nervous to ask any questions to the doctor. So it creates a difference between the patient and the medical staff, and they are not aware about the disease and proper treatment for that. So good communication is quite necessary between the two to become to get rid of this illness. Thank you.
Absolutely right, so Elena. Very good points. Would you like to comment and just list out 2-3 points which you saw in the video which were not done optimally, just to start a discussion?
Dr. Param, sorry to interrupt.
I can.
Yeah.
We do have a few comments in the chat box.
Okay.
Yeah.
All right.
I see that showing that one is busy and don't have time to communicate with the patient is bad. Yeah, the Asha worker looked so busy. It may be her reality, but could have done better. Yeah, that's very important. The Asha worker says, no, I can't sit. I am busy. So that itself has to be changed. That's true. Then closed questions, distraction. Yeah, in between conversation, the phone was ringing, which is a usual communication barrier nowadays. Then blaming the patient and caregiver. Yes, the Asha worker was asking, why are you not taking anything? And she is blaming the caregiver. Why are you not giving anything to the patient? Yeah, giving her own solutions. Blaming and shaming the patient and caregiver. No empathy, very judgmental. Blaming on patient condition. Yes. So I think you have covered most of the points. Param, would you like to add anything, or we just show the points?
It's very, very, very nice points, and exactly they picked up, and most of these points we already discussed. So it's nice people have picked up. So this is what it is. I'm sure it is a simulated video, and these are our faculty in doing that for training purposes only. But it's good that to see that what I do, because many of us unconsciously do that. So I think most of the points have already been made. Lack of patience, ignoring the emotion. So do you have a good communication video also?
Yes.
Okay, let's go to that.
Senior, you can continue with that video.
Asha worker Raji.
Yeah. Good point. So you see the same thing done in a better way. And if you notice, probably, I don't know, I mean, this is just video we made, but it didn't take very long because you were not interrupted. You were focusing, and this myth about having to spend too much time if we are good communicators is not totally true. So yeah, that's a very good video. Thanks, Dr. Sunil and Senior, for that. I just wanted to, go back. I think there were some points in the chat box. I will have to leave another 10 minutes time. So empathy. Very nice point, Sunita Mary. And I think did you ask that question? Let me just go up. There were few up. There was this. No, this is Maria. Maria had asked this question that where can people learn to learn good communication with the patients, and all these things which we have said are learnable. So one is, of course, these small sessions, but if you are interested, there are even pallium sessions or other palliative care societies. I do it for the neurology, Indian Academy of Neurology, Indian Epilepsy Society. So if you look for, you will find there are meetings happening only on communication. And even when we do our proper communication courses, this is a very abbreviated thing in 2 sessions. It almost goes for half to 1 day. And we can have breakout sessions. We usually enact these things so that people have a practical thing in small subgroups. So any of such things can help. But in addition to that, someone has said empathy. So that is very important. This is learnable, but the learning will be useful only when we change a little bit inside us also. And if I have to use a bottom line, it will be genuinely caring for the patients, genuinely being empathetic for the patients. Then these things will be much more easy to learn. Otherwise, if you want to learn it like a rote learning, we will more often falter than not when we are in a stress situation and doing that. So there are ways to learn about it. Then there was another point. Can you suggest some points on breaking bad news? So we actually have Rajni. There is a full session. And the next thing on Friday, day after tomorrow, is totally on breaking bad news. So we will discuss this topic that time. Anything else? Did I miss anything among the questions, or did we take them up? Let me go up. Joshi Jonas, you said that during illness, patients are emotionally inclined to communicate their concern. How do we see in identifying the facts to be considered? Do you want to verbally clear what exactly was it you were trying to say, or you want to just unmute yourself?
Well, when the patient is communicating with a lot of emotions, they mix up various things simultaneously, and the caregiver has to be careful in how identifying what is the medical concern, what is the care concern, and what other areas needs to be addressed. And one person cannot address all the issues. So therefore, with the sieving is, you have to identify what factors can be handled by the person visiting the client, and what concerns the family could handle. These things has to be identified, but then it has to be identified very, very succinctly, I would say, not giving a loose end, but making sure that everything is picked up as early as possible.
Absolutely. Very nice point, Jashi, and very nice suggestions also. So this is what we were talking about when we said that, some doctor feels they're overburdening me with their emotional issues, which I am not supposed to handle, or I'm not trained to handle. So they will say everything, they become like, I don't know what is the psychiatric term for it, dependence, codependence, no, not codependence, transference, whatever. They become very, very attached to their medical carers. And they want to tell everything, like, sometimes we may know that the doctor can't help us in this, but we just want to say everything. We are in an emotional, that's exactly what you said. So sieving is important, But the point here, which I would like to a little bit add, is that no harm noting down in our mind or literally what they're saying, because they are using it as a point of contact. Well, it could be us as doctors, or it could be the nursing staff who spend more time. So whoever gets told these concerns, what we can do is we can counsel regarding that. As you said, something maybe for the family, but the patient is not able to tell this to the family. The kids are not coming, or they feel feeling lonely. We can talk to the family. We have family meetings. Beyond that, if there is a depression or other kind of illness which we can't directly deal, we can at least channel it to different people. So what I would say is the ideal way of sieving is sieve it. What we are trained to do, we do it. The rest of it, either we help them do it or channel them to the right way. So that is also part of our responsibility. At least we know, and then we tell them, okay, we'll ask for a psychiatric consultation for you, or we ask for a physical therapy consultation. You're having these aches and pains which may not be totally related to the disease, maybe just because of lying. So sieving and then channeling, triage kind of, we may act as a triage on behalf of the patients.
So there was a question, Dr. Param. If the patient is paralyzed, how could we communicate with the patient?
Yeah, so absolutely. We face this every day in neurology with strokes. And as I mentioned about the story also, that it's maybe very, very difficult for them. One is, which I've noted, is that to know, if we medically know that the patient is conscious, many times they just have motor aphasia, they can't speak, but they can listen. So the staff and their family has to be told that this patient is understanding everything. Even this locked-in syndrome, this patient I was talking about last month only, he was still here with us till a week back, and the young guy and with locked-in syndrome, which means he was fully conscious, fully intelligent, fully communicating and understanding. And the look on the patient is comatose, of course, because they can't move anything. And there were people coming, their attendants, relatives coming. So unfortunate, this has happened. Is he ever going to, don't think he's going to wake up, stand up. Then I just saw it, and I just had to instruct our staff also and their family also. Maybe they didn't know that this patient is totally non-communicative, but fully conscious. So this is one point we must all remember, that not talk on the patient without involving the patient. We always encourage people, even if they're non-communicative, and if you think they're conscious or they have a sensory available, keep talking to them. We tell the family, keep talking to them. And the last point is how to communicate. Well, we try everything from writing on a pad. There are neurological conditions where you cannot speak, but you can write on the pad. If you can't write, we sign for gestures. Even if they can't do gestures, like again, coming back to, this is one of the most, I keep coming to lockdown, is most debilitated person who cannot communicate. By making a questionnaire where they have to only say yes or no. If you go see that movie, that is what they do. They have this code language for blinking the eyelid once, blinking twice. So, or if they can move a hand, just, are you having pain? Just press my hand. If you're having pain, okay, yes, pain. Is it in your leg? No. Is it in your tummy? Yes. So we have to devise different ways of, short of, if we have that available easily, what Stephen Hawking used, those brain computer interfaces which are coming. Hopefully we'll have them sometime where you can think and it will come on the board. But before we have them, or until we have them, we have to devise these innovative things. And there are OT people, occupational therapy people, who are rehabilitation people, who are very well versed in that. We should take their help in that kind of communication.
Even you can use pictures, and maybe the patient can look at the picture and we can point it towards. So there are many techniques by which you can communicate. We had a patient with motor neuron disease for whom only he can move the mouth, but no other parts of the body cannot move. So actually, with some engineers, we have devised a mouse which can be held in the mouth, so that he can write something in the monitor. So that's what that patient was doing. So there are many things you can do, even if the patient is unable to communicate by usual means. Yeah.
Yeah, good points, Dr. Sunil.
Yeah.
I
And I
agree,
see that
yeah.
there is a question regarding when the patient asks about the disease and the family does not want to communicate it to the patient. So this is a very difficult situation which we usually encounter every day. And I think this will be covered in the next session.
Yeah, in detail. Mostly it will be about this. Half of the discussion actually in that session is about collusion, and that is
Yeah.
the actually formal topic also, collusion, when the family doesn't want to communicate. Still, we are looking for the ideal, I'd say idealist situation, but there are general guidelines which we are obliged to legally and ethically to get the best out of the circumstances where we can. We'll talk about it in detail. I'm afraid I'll have to leave it for, but this is the whole talk day after tomorrow. So we'll be covering all this in that.
Okay. Okay, you can leave, Param. I will continue.
Yeah, you can
So thank
continue.
you.
Take
Thank
a
you for
part.
being with us and
Yeah. I
having a
have
wonderful
another
session.
meeting. So yeah, with something going on. So unfortunately, this 4 and then again on Friday there's a meeting. So I'll take you to. Thank you very much. See you again on Friday, and you can carry on, Dr. Sunil Sini.
Yeah. So I see there is another question. Palliative care patients always say, "Please send me home." How to reply? Okay. So, Doctor, I see this is by Dr. Ramachandran. So,
Dr.
can you,
Chandrasekharan.
Dr. Chandrasekharan? Okay. So, Dr. Chandrasekharan, will you be able to talk about something specific? Because we also have an inpatient unit where we admit patients, and our problem is that patients don't want to go home once we get patient is admitted. So can you please explain? Dr. Ramachandran?
Actually, Dr. Chandrasekharan, can you
Sorry,
unmute from your
Dr.
end?
Chandrasekharan.
In between, sir, Dr. Tassin has raised her hand.
Yeah.
Dr. Tassin, if you have anything to add on, please.
Hello, good evening, sir. Can you hear me?
Yes. Please
Yeah.
go on.
Good evening, sir. Sir, I am a physiotherapist from Chennai, and I have been taking care of a patient who's had a fracture, hip fracture. So at present, now she's recovering from her fracture and everything, and there is a caretaker along with her. But the caretaker is always demotivating the patient, telling like, you just need to walk fast so that I can go to visit my family. I am been with you throughout the day and night. I am here with you. So why can't you get up and walk? Why can't you get up and do more things on your own? So this actually demotivates the patient. So how do I, like make them better? Because I motivate the patient telling like, yes, your condition is improving. You are getting better. You're able to sit. You're able to stand and everything. But then this caretaker throughout the day, she keeps demotivating. So how do I face this problem and like, get the patient get into betterment?
Is the
So,
caretaker a family member or a
no,
paid
no, no, no,
caregiver?
paid caregiver.
So I think you have to talk to the first to the family member
Okay.
and tell him this is what I think. And with his permission, you should talk to the paid caregiver. Don't
Okay.
blame the caretaker.
Okay. Okay.
That's most important. But instead, you can say that because of your care, he's getting gradually improved. And I would also like to involve you in the care more so that he will get better. But I also want to tell you something which is very important. Then you come up with your specific agenda that I can be. I have heard that you were saying like this. So will it be better to tell him that it will take some time to recover from this? Because from the medical knowledge, I understand that it will take some time. So that's why I am telling you. So I think you are the good person to motivate her. And I also see that because of your involvement alone, the patient is getting improved. So that the paid caregiver also, we are giving that status. Okay, you are an important person. That's a message that we are giving. We cannot blame that person.
Yeah, sure. Okay, sir. Thank you.
Yes, Sunita, this is a very common problem which we face every day. When we say the patient that you need to go home, they say, no, we don't want to go home. If possible, they want to be here for lifelong. It is not possible for us. So anybody else has your own experiences regarding, Dr. Sorry.
Hadisha Crystal.
Yeah.
It's a line. I don't know if I spelled your name right or. Sorry, we can't hear you. Your voice is breaking. Yes.
I have a question.
Ma'am, your voice is breaking. We cannot hear
So
you.
usually as it's Hadassa. So I have a question. So oh, I have a question. Am I audible?
Now you are audible. Yeah.
It's not good. So my question was, as Dr. Parampreet sir said that when there is a emotional problem and there's a lot of concerns of the patient and they tell everything to the doctor, and the doctor cannot solve all the problems of the patient, which is obvious. So maybe sometimes the doctor might suggest that you go to a psychologist, or there's a counselor down there, or there's a social worker down there. But in India, the problem is that our society in general don't like mental care, healthcare workers, because they think it's for the mentally ill people and not for addressing their emotional problems as well. So does that onus fall on the doctor to convince, or to suggest it in such a way that the person goes to the counselor or the social worker, or is it just that the doctor gives them a tip about it, that you can go to a counselor and then completely leave it to the patient or the caregiver whether they want to go or not?
This is an important question. The patient might have many problems. It might be some physical problems, it might be psychological problem, and it is also true that there is social stigma on mental health issues. What we if you are a single person managing the patient, then I think it would be our responsibility to listen to the patient and see what all factors we can have solutions. Sometimes we may not have solutions. Even if we send this patient to another person, there may not be a solution. But even if it is psychological problems, we can have a we can give time for a patient hearing. And if you think, okay, this patient needs more professional guidance, and you want to send to a psychiatrist or psychologist, you can tell the patient that, okay, I can give some solution to these problems, but I think it is important for you to meet a specialist for this particular problem. And you may tell that it is you have to also tell the person that psychiatrist is not only a person who treat the madness, but it is also for something. If you have some psychological problems or problems with your mind, they will help you to resolve or relieve that. So I think that would be the way to tell them, because there would already be a social stigma on seeing the psychiatrist. So if we think that the patient need a psychiatric consultation, then we should tell the patient, okay, this is what is necessary.
Okay. Okay, sir. Thank you, sir.
Any other comments or questions? Dr. Sunil, if there are no more questions or comments, shall we wind up the session?
Let me summarize,
Okay, sir.
Inia. So all of you, I am sure all of you understand the importance of communication, and the communication is it can be done in many ways, verbally and non-verbally. And I would say that the non-verbal communication is the most or it is more non-verbal communication have yeah, Dr. Sarida want to say something?
I think it was accidental, sir.
Okay. So if you take the communication, non-verbal communication forms major part of communication, and literature says about 60 to 90% of communication is through non-verbal communication. And the non-verbal communication includes many aspects, but few are eye contact, your facial expression, uh, and it is important to sit and talk. The patient as well as the professional should sit and talk. Then they should have good posture. Then we should respect the space between the two people, which is known as buffer zone or comfort zone, etc. Then our tone of voice, which all are very important when we communicate with the patient. And there are many do's and don'ts in communication, and some of the don'ts which we usually um, um, when we see somebody communicating, they make some mistakes, but they think that they have done it in a good way. So these are the some don'ts are assuming. So uh, this is something which we usually encounter in our daily life. So if somebody is smiling, then we may think that why this person is smiling, uh, and we may assume she's smiling because of this. So it should not happen. I would give you an example. Suppose a person is suddenly crying in front of you. So what would you do? It's our natural tendency to console the patient. So we may tell them, okay, don't worry, uh, you will get relieved, or so many things to console the patient. But we should go and ask the patient why you are crying. That's what we wanted to understand. So we should not assume why the patient has cried. So we have to find out the reason for cry. So don't assume. That's most important thing. Then don't ask leading questions. So as doctors, somebody may ask, your pain is better, isn't it? So that means the doctor is leading the patient to get an answer what the doctor wants. Doctor has given medication yesterday, and he wants to hear that patient has good pain relief. So he will ask leading question. So leading questions should not be asked, and the medical jargons is another thing which we should avoid, because all of us have had many medical words which the patient cannot understand. So we have to speak a language which the patient understand. And there are many other things like false reassurance, premature reassurance. These are don'ts in communication. And one thing which we should always do in communication is active listening. And open-ended questions is what we should ask the patient. And there are many barriers in communication, which might be from patient side or from the professional side. So with that, I think I will wind up the session. So thank you for your active listening and participation. Senior?
Thank you, Doctor. Thank you for your valuable time and for being here with us today. Thank you all for joining us, and I have shared the feedback link with you all. Please fill it up. And one more request, those who haven't submitted their case presentation yet, kindly share it with our mail ID, that's tipseco@palimindia.org. If you have any doubts regarding that, please feel free to contact me. Thank you all. We'll see you on the next session on Friday, that is on communication part 2. We'll see you. Bye.